Welcome back, guys. So this is the second part of heart sounds. So in this chapter we will learn about the abnormalities of S2 sounds. Also we will add the knowledge about added sounds. So before jumping to those topics, I want you to understand few basic concepts regarding stenosis and regurgitations so that your ideas will be clear. So stenosis. What do you mean by stenosis? It is difficulty in opening valve. And what about regurgitation? It is difficulty in closing a valve. So in this difficulty in opening, you can call it as a narrowing. So for mitral stenosis, mitral valve has difficulty in opening. Similarly, in MR, it will be difficulty in closing. Same goes with AR, AS, PR, PS. Okay. So this is one of the most important thing you should know. You should understand and make clear for the future concepts. So for first time, we will learn the what is S2. So S2 is closing of AV valve and P valve. So it is indicated as A2 and P2. So what exactly happens is during inspiration, so this is your lungs and this is your heart. So whenever there is an inspiration, size increases, that is thoracic size cage increases. So as soon as this size increases, the blood venous return to right atrium and right ventricle increases. So this will take longer to empty. It's obvious, right? So if the blood is coming to right ventricle in a large quantity, so it takes long time to throw that blood to pulmonary veins. So there is a delayed closure of P2. Okay. So what usually happens is A2 then P2. So this gap, you will get this gap in inspiration. So normal splitting, that is A2 then P2, is in inspiration, right? Second, S2 sound. So what are the factors affecting A2 and P2? The first one is the pressure. The second one is the mobility. Third one is vessels pressure beyond valve. Fourth one is flow across valve. So how does it affect in A2P2? Suppose there is a pressure, that is a hypertension. So how pressure affect the A2P2? Suppose this is your valve which has to open in this side, okay, and this is your heart, that is whatever part, it might be right ventricular or left ventricle. So it will push blood in this direction, and this is the pressure in aorta or pulmonary artery. Okay, so what if the pressure in this channel is increased? This heart has to work a lot to push blood from its cavity, right? So to push the blood from here to here, this area has to work more, so it will increase its pressure as well, right? So if the pressure from here increases, then the opening of these channels, opening of this valve will be loud, right? So for this, if there is a systemic hypertension, if there is pulmonary hypertension, we can get loud A2, and here we can get loud P2. Just understand that if the pressure in a pulmonary vasculature, there is a increase in pressure, then the right ventricle has to put more effort to throw that blood into the pulmonary vasculature. So to put more pressure, the valve will open very fast, or it will create the loud sound. Okay, so this is the first thing. Second is the mobility. So more the mobility, more will be, greater will be sound. Then vessel pressure beyond this valve is just like a hypertension and pulmonary hypertension. Flow across the valve is like a hyperkinetic blood. Hyperkinetic conditions will create loud A2 and P2. So these are the four factors that affect the sound of A2 P2, that is a S2. What are the abnormal S2s? The first one is loud, soft, single S2, that is no splitting. Third one is wide splitting, and fourth is reverse splitting. So these are the variations that we get abnormal S2. So let's go for a loud S2. How can we get the loud S1? Either we have loud A2 or we have loud P2. So where we can get the loud A2? We can get in hyperkinetic state like anemia and fluid overload, or even pregnancy. So what happens here is the blood flows in a so much rush that the valve will hit on the surface, so to create the loud S2. So it will create loud S2. Then in hypertension, Here also the afterload will be the increase. Then if the aortic valve is bicuspid valve, usually it has a 3 semilunar valve. But what if we have a bicuspid valve, aortic valve, then it will create the loud A2. What are the condition? We can get the loud P2 here, pulmonary hypertension and in ASD. Why ASD? Because there is a blood flow from left side to right side. So the right side will have the more blood. If more blood is there is a more pressure gradient, volume gradient. So it will hit on the surface, that is valve will close more forcefully. So this is the variation of loud S2. Now let's see soft S2. So how we can get a soft S2? If we have soft A2, if we have soft P2. Where we can get soft A2? It's AS, that is degenerative. So it is so stiff, that it fails to close the valve and it has a minimal mobility. That's why it is a degenerative and it will create the soft A2. Similarly, about soft P2 is PS, that is degenerative. So these are causes of soft and loud A2. Sorry, loud S2. Now what is the single S2? Single S2, or we can call it as a narrow splitting. I told you earlier that in inspiration there is an increased venous return, so that there is a physiological delay in closing P2. But there are some few cases where this delay is not there. So even in the inspiration, there is no delay in P2. So what are those conditions? The first one is portal hypertension, severe portal hypertension. What will happen in this condition is there is so much pressure from pulmonary artery that this delay does not occur. Second one is aging. Third one is atresia of semilunar valve. Fourth is severe AS or PS. So here we won't be hearing from A2 or either from P2 due to the severe aortic stenosis or pulmonary stenosis. Aging plays an important role for single. Then atresia. Here also there is a no mobility. So here no mobility. Now wide splitting. Normally A2 and P2 splitting is there in inspiration, and the time between the splitting is 50 millisecond maximum. So if it is more than 50 millisecond, we called it as wide splitting. So there are two types of wide splitting. The first one is variable. What do you mean by variable? At some point you will get the splitting and in some point you won't be getting it. So what do you think, what should happen so that we could get the white splitting, either early A2, or we can get, or we should get late P2. So where we can get early A2, if there is a LV pacing, if there is a LV ectopic, and where we can get late P2, if there is a right bundle branch block, if there is a hypertension plus right ventricular failure, if there is a pulmonary stenosis, if there is a VSD, if there is a cardiac tamponade. Now I'll explain everything. Left pacing and left ectopic, what will happen? There is a stimulation of left ventricle early, that is a depolarization. So we will get early A2. What will happen in RBB? Since left bundle branch depolarizes first and then it will depolarizes right bundle branch, but here there will be no depolarization. So what will happen? A2 we will get on time, but due to RBB we will get late or delayed P2. So what happened in hypertension and right ventricular failure? In right ventricular failure, the contraction of right ventricle is compromised. So there is a delay in closing P2. In pulmonary stenosis, what I have told you, that the stenosis means there is difficulty in opening. Since there is a pulmonary stenosis, the pulmonary valve opens late. So there is a delay in P2. Similarly, in VSD, there is a left to right shunt. So right will get more blood. Then it will take more time. So delayed P2. So in cardiac tamponade, there is decrease in filling of chambers. So if there is no filling, it will take more time. So these are the causes of variable wide splitting. So what is the second one? Second one is fixed wide splitting. So we can get fixed wide splitting in any cause of variable wide splitting plus right ventricular failure. So just remember that if there is a question mentioning that these causes and they will ask about the variable, do we get the variable splitting or we get the fixed wide splitting, then you must answer according to this chart. Also, if they mention right ventricular failure with any other causes, then you must understand that they are pointing towards the fixed wide splitting. Now what is the reverse splitting? Reverse splitting will heard in expiration, but it won't be heard in inspiration. Normally what happen, A2 and then P2, right? So reverse splitting is P2 occurs first and then A2. But in inspiration, there is a physiological delay of P2. So you don't get it in inspiration. So this is the thing which only occur in expiration. Now, how could we get the reverse splitting? There must be early P2, right? Or there must be delayed P2. So what are the causes of early P2? If there is a right-sided pacing, right? Where we get the delayed P2, sorry, delayed A2. It's either early A2 or delayed early P2 or delayed A2. Here, if it is left bundle branch block, if it is aortic stenosis, if it is aortic regurgitation, if it is HCM. Now, how will we get delayed A2 in LBB? LBB, left bundle branch will depolarizes first and it will depolarizes RBB. Since this is not happening, so the RBB will depolarizes first and there is a conduction of intermyocytic here. So it is a delayed conduction and delayed depolarization. So if there is a delay, then A2 will be delayed and P2 will be early. Aortic stenosis, there is difficulty in aortic opening, so it will take more time, so delayed P2. Similarly in AR, it is failure to close, so take more time. Hypertrophied cardiomyopathy, a rare cause, but we can get delayed A2. So these are the variations of S2. Let's revise again. It might be the loud, soft, single S2, wide and reverse splitting. We studied the wide splitting, which is a variable and which is fixed wide splitting. In variable, it might be early A2 or late P2. In fixed wide splitting, it is right ventricular failure with the any cause of wide variable splitting. In reverse splitting, it might be the early P2 in case of right pacing and delayed A2 in case of LBB, AS, AR, HCM. So these are the variations of S2. Now there are few added sounds. So S3, S4, opening, snap, ejection, click, pericardial, knock, and tumor flop. So these are all added sounds that can occur in systole, systole or in diastole. We have studied S3 and S4 in previous video. In this video, we will be studying these other causes. Let's divide these sounds in systolic added sound and diastolic added sound. So what are systolic added sounds and what are diastolic added sound? The systolic added sound is ejection, click, and mitral valve prolapse. It occurs in early systole. What about the diastolic added sound? It is opening, snap, S3, pericardial knock, and S4. So these are the classification of added sounds. So in this we have covered this S3, S4. Now we have to cover opening stab, ejection click, MVP, and pericardial knock. So before that, I want you to revise the cardiac cycle. So what happened in cardiac cycle? S1. What is S1? It is closing of AV valve, right? After closing of AV valve, what happens is isovolumetric contraction. Here all valves are closed and there is no volume change and contraction starts, right? After isovolumetric contraction, there is a opening of AV and PV valve, and what we called it ejection click. Now after ejection click, what will happen? This valve will close, right? So closing of AV and PV valve, what we called it? That is S2, that is closing AV PV valve. Then there is a isovolumetric relaxation and then diastasis. So this is the basic heart cycle that follows the S1 IVC, open ejection click, S2 IVR, and diastasis. Now ejection click. What is ejection click? So ejection click happens right after isovolumetric contraction. So whenever the heart starts to contract, AV and PV valve open so that blood will go to either pulmonary vasculature or systemic vasculature. What happens in aortic stenosis is it is difficulty in opening. So left ventricle has to put more pressure to open AV valve. Since there is a requirement of more pressure, the sound will be loud. So we will get ejection click. Please remember that ejection click is not the normal sound. if there is a presence of ejection click, it means there is some pathology around it. Similarly, in pulmonary stenosis, it is the same pathophysiology for this as well. If it has a bicuspid aortic valve, similarly, this will cause difficulty in opening. So the left ventricle has to put more pressure. So the more the pressure is, the greater the sound. So we will get the ejection click. So this is the ejection click. Fine. So first sound, we have completed the first sound. So we have covered this one. We have covered S3. We have covered S4. Now what is opening snap? Okay, one thing is that ejection click when the aortic valve or pulmonary valve opens at the start of systole. So it happens at the start of systole. Okay, next is the opening snap. What is the opening snap? Opening snap means opening of mitral valve and tricuspid valve. When this mitral valve and tricuspid valve opens, when there is a diastole. So in early diastole, MV and TV opens. So when we will get this opening snap, this is also not the normal thing. If we are getting the opening snap, that if the question is mentioning opening snap, then there must be something, the pathology related to mitral stenosis or tricuspid stenosis. So in mitral stenosis, what will happen? It is a difficulty in opening of mitral valve. So left atrium has to put more pressure. For more pressure, opening will be forceful and it will create loud sound and we will get opening snap. Understood? So this is the opening snap. Now there is some timing, that is S2 and OS interval. S2 is what? Closing of aortic and pulmonary valve, right? OS is opening of mitral valve and tricuspid valve. Now aortic valve and pulmonary valve closes so that the diastole could start. As soon as the diastole starts, after that there is a opening of mitral valve and tricuspid valve, right? So the distance between the timing between closing of this aortic and pulmonary valve and opening of mitral and tricuspid valve is very important. So let's suppose there is a mitral stenosis. So opening of MV and TV is delayed. Sorry, only MS. Mitral valve is delayed, right? Since the opening is delayed, but the timing of closing AV and PV valve is constant. Suppose this is the point A and this is the point B. Now suppose at this point there is a opening snap and there is a S2. What happens whenever there is a mitral stenosis? This point will shift to here. So now the point will start from this A to B. So we can say if the duration of opening of mitral stenosis is directly proportional to severity, timing to open mitral valve is directly proportional to the severity. So we can say shorter OS, shorter S2 OS, more severe MS, right? This is the dictum. So shorter the S2 OS time, more will be the severity of mitral stenosis. So these are two things which are very important, and you must understand the what is opening snap and ejection click. So we have covered this opening snap as well. Now what is a mitral valve prolapse and pericardial knock? I will explain in short in this chapter because we will be studying this pericardial knock in detail in other chapters. For the time being, just remember the mitral valve prolapse, we will be getting systolic added sound, and in pericardial knock we will be getting diastolic added sound. So these are the abnormal sounds or added sounds. Now what is the tumor plop? Tumor plop we will get in atrial myxoma. So how should I explain it? Suppose this is the pipeline and there is a ball of the same side, and you have attached this to a string. When you throw this string to the opening of pipe, it will fix perfectly. So as soon as this ball hit on this opening, it will create the sound, and this is called as plop. So this is the heart. There is a ball and there is a opening of mitral valve, and there is a hitting of this ball fitting perfectly for the size, and it will create the sound like the plop. So this is tumor plop we will get in atrial myxoma. Okay, now murmurs. So what are murmurs? Basically murmurs are turbulence. What do you mean by turbulence? Suppose this is the pipeline. If there is any abnormality in the pipeline, then this water flow will be turbulence. So this is called the turbulence. So it is just a murmur is just a turbulence. So what are the different kinds of murmurs? So there are systolic murmur, and there are diastolic murmur. First of all, I will tell you every murmur and how exactly it occurs. Then I will tell you the cheat code about how to diagnose murmur, like at which condition which murmur we will get. So for the systolic murmur, we have ejection systolic murmur. So where we get it? In aortic stenosis and pulmonary stenosis. So how do we get it? First understand, suppose this is aorta, this is our left ventricle. So aortic stenosis means what? Stenosis means failure to open, but as soon as it opens it will create the turbulence. Like suppose this is your pipe and this is your pipe. So now there is a stenosis, that is decrease in space. So what happen? Sudden decrease in the diameter will increase the turbulence in vessels. So this is the turbulence which we get as a ejection systolic murmur. Second one is pan systolic murmur. Where do we get this pansystolic murmur? In mitral regurgitation, in tricuspid regurgitation, in VSD. So in mitral regurgitation and TR, how do we get this murmur? Let's study. Suppose this is the balloon, this is opening. Just consider this is as a LV, a balloon. Now, if you close it partially, suppose you close it partially and then you compress balloon, then we will get the sound as a leaking air. Similarly, that happens in the mitral regurgitation and tricuspid regurgitation. Like this is the your AV valve. This is incompletely closed, that is partially closed, and whenever there is a systole, the blood will go through this area continuously throughout the systole. So why it is called as pansystolic murmur? Because it is the throughout the systole. Now what about VSD? There is a septal defect in VSD. So whenever there is a LV contraction, some blood will always leak from this defect, giving you a pan-systolic murmur. Now what is the late systolic murmur? This late systolic murmur we will get in mitral valve prolapse. Now how do we get this? So suppose this is your heart, this is your valve. Now what happens in mitral valves? Initially mitral valve works normal, and at the late systole, valve goes to left atrium due to caudate tendon. So whenever there is a valve which goes to left atrium at end of systole, there is a leakage of blood which creates murmur, that is turbulence. Okay, so these are the systolic murmurs. Now we will learn about diastolic murmurs. Don't worry, I will tell you the proper cheat code for this murmurs. For diastolic murmur, let's divide it into early diastolic murmur, where we get it aortic regurgitation, then pulmonary regurgitation. So how do we get it? What happens in diastole? What happens in diastole? Let right ventricle and left ventricle relaxes, and opening of aortic valve and pulmonary valve closes. But since there is a regurgitation, that means difficulty in closing. So what will happen? We will get we will get turbulence. That is, blood will leak from these aortic valves, creates into early diastolic murmur. Okay. The second one is mid diastolic murmur. Where do we get this mid diastolic murmur? In mitral stenosis and tricuspid stenosis. Stenosis failed or difficulty in opening, right? So where mitral valve opens in diastole, right? Since it is difficulty in opening and it opens in diastole, so it takes time to open in ventricles. So it opens in mid diastole. So do you understand? This mitral valve supposed to open in early diastole, but since it is difficult to open mitral valve, time to open takes a lot of time to open in ventricle. So it is a mid diastole. Similarly, we can formulate for tricuspid stenosis as well. What is the continuous murmur? It occurs in AV fistula. It occurs in patent ductus arteriosus. We will learn this in cyanotic heart diseases. So these are the main three types of murmurs that we will get in systolic murmur, diastolic murmur, and continuous murmur. Now, what is the cheat code? So, what I have told you about stenosis, difficult to open, and regurgitation, difficult to close. Now, take your example as a mitral regurgitation. Now, when it opens, mitral regurgitation means difficulty in closure. Mitral valve closes in systole. So this is systolic murmur. Now it is pansystolic because continuous leakage. Take a second example, aortic stenosis. What do you mean by stenosis? Difficult to open. When valve open in systole, and at which timing it opens? Early. So it is early systolic murmur. Take another example, tricuspid stenosis. So what is stenosis? Difficulty in opening. When it opens in diastole. Where it opens in diastole? Mid diastole. So it is mid diastolic murmur. Now what are the remaining? AR, TR. Just formulate this by your own and you will get the answer. So whenever you are being asked about the valvular defect and there is a question for which murmur you will get, then you have to, you know how to formulate it. You just have to understand when this particular valvular event occurs in which state. So as soon as you get the state, you will able to answer this most of the questions. So these are the topics for abnormal heart sounds and heart sounds. So I hope you will understand this and you will remember all the concept behind this all, and you do it better in your question solving capacity.